Hi, everyone, and welcome to today's Research America webinar. And as always, thanks for joining us, for your partnership. And if your organization is not a Research America member, I think you've heard my pitch before, but please get in touch with me or someone from our team. We would love to have you as part of the Alliance, and it will make us all that much stronger in trying to advance medical and public health progress. So today we are absolutely thrilled to be joined by Dr. Amira Roess. She's a professor of global health and epidemiology at George Mason University. And Dr. Roess is going to discuss with us what's known and not known about the COVID-19 Omicron variant and its implications for the trajectory of the pandemic going forward. Before we opened up the webinar, we already had about 30 questions going for Dr. Roess. So I think this is just going to be a wonderful and informative discussion. As always, please type your questions into the Q&A box or chat, and we will do our best to pose them when we get to the Q&A portion of the session. And with that, let me turn it over to you, Dr. Roess.
Thank you very much for having me. So let's go ahead and jump in. I'm going to provide an overview of coronaviruses, a bit of the history, and then I'll talk about Omicron, some of the differences between Omicron and Delta. We'll go over the epidemiology, the effectiveness of vaccines. I'll also preemptively answer some of the questions that came through already regarding testing, masks, and the future, and at what point could we, live with the virus versus sort of the situation that we're in right now, where we're really struggling to house our emergency room staff and other healthcare staff. So coronaviruses, they're part of a pretty large family of viruses. Some of them target humans and others cause illness in animals. The ones that we really knew a lot about prior to 2002 generally caused mild illness or the common cold in humans. I will say that I've been working on MERS coronavirus since about 2012, before the COVID-19 pandemic. And a lot of my colleagues, veterinarians, wildlife biologists, they were constantly saying to the human health folks, hey, you guys need to start paying attention to coronaviruses, because what we find in the animals that we deal with is that sometimes when a coronavirus targets a specific species, it could really be devastating. And we got our first real glimpse into this in 2002 with the emergence of the first SARS, right? That coronavirus really caused panic throughout the world. It was a pandemic and from a virus that was causing a pretty high, what we call a case fatality rate of those individuals who became infected. A large percentage of them ended up very sick, needing hospitalization, and a fair percentage of them ended up dying, right? So the case fatality rate was hovering at about 30%, depending on which study you look at. And that is a very high case fatality rate. So it disappeared. By 2004, we really felt that we were not going to be dealing with this specific coronavirus that caused SARS anymore. We couldn't find it in these intermediary hosts. We couldn't find it in the human population. And what happened when this occurred was that the funding and the attention given to coronavirus research, especially here in the US, really dwindled and went away. And we didn't pay much attention to coronaviruses until 2012, when MERS coronavirus popped up. This is the Middle East Respiratory Syndrome coronavirus. That one emerged in 2012 in the Middle East, and within 6 months, it was generally understood that individuals who came into close contact with camels were at an increased risk of getting MERS. But one of the really interesting parts of this is that oftentimes it would sort of dwindle down after it infected a handful of close contacts. But then we saw it emerge again and again, and we started to see human-to-human transmission especially in hospital settings. The number of cases from MERS have really been sporadic over the last 5 years or so. And again, in the US, when we heard about MERS, there was some attention and funding allocated towards coronavirus research in 2012 and 13. But once it was sort of recognized that this isn't going to be a very severe pandemic and it wouldn't be a real issue here in the US, the funding for basic coronavirus research also basically went away. So then you fast forward to 2020, 2 years ago, and right, we all know what happened then. Another coronavirus emerged. It was unclear whether or not this was going to be a coronavirus that would cause a pandemic, and within a couple of months, it was we learned that yes, this is going to be the big one. So corona, Latin for crown, and what you basically see when you look at the coronavirus are these spikes around the exterior. It is a small virus. It's an RNA virus. It's, for some of us, it's really interesting to note that even though it is a relatively small virus, it is still twice the length of the influenza virus. Coronaviruses were first sort of discovered in the 1930s when we were aware of how they could cause outbreaks in certain species, non-human species. And then in the 1970s, there was sort of a extra interest in coronaviruses among mainly animal or veterinary health specialists. So many coronaviruses are found in bats, and we think that the ecological reservoir is in bats. So bats are carrying them, but the bats themselves, they never develop any kind of illness. What we've observed with the first SARS in 2002 is that there could be what we call spillover events, and these civet cats and some other species become the intermediate animal host. And it's from human contact with these intermediate animals or hosts that humans end up picking up the virus. So with MERS coronavirus, this part of the transmission chain is pretty well documented. Some humans who have close contact with camels do end up picking up the MERS coronavirus that the camels are carrying, and then some percentage of them end up being ill, and a small percentage of them end up transmitting it to other humans. However, the human-to-human transmission of MERS coronavirus is not very efficient, nowhere near what we're seeing with SARS-CoV-2, the virus that causes COVID-19. So with the COVID-19 virus, what we really don't know yet is this piece right here. And honestly, this link is still unclear. So a lot more work is underway to try to identify what the intermediate animal host might be. And I think this is one of the puzzles that a lot of us that are studying coronaviruses are trying to carefully wrap our heads around. So there's a lot of what we call interdisciplinary research that's ongoing to try to understand some of these transmission dynamics so that in the future, we could understand a bit more about spillover, this both from bats to intermediate hosts, and then from these intermediate animal hosts to humans. If we can understand that, then maybe we can come up with interventions, to really reduce that risk. I wanted just to sort of share an overview of the ongoing MERS coronavirus research that our team is working on. We're trying to really understand, where are the camels picking up the virus in the first place? Is it really from bats? And the data are really inconclusive at this time, but there is some compelling evidence that that might be what's happening. And so we're doing what we call interdisciplinary work, which brings together experts from the social sciences, anthropologists, people who work with camels, who understand commodity networks. We also have the sort of traditional human health folks, the public health folks, the veterinarians, and here we also have wildlife biologists and others that typically don't work together on these large scale studies. And then we also have environmental science experts and experts who study things like vegetation and weather patterns, because all of this works together to help us really understand when a virus might spill over and in what conditions a virus might thrive and thrive well in humans. And then, you could see that really strong human-to-human transmission. So we're going to forward to Omicron and other compared to other variants. So what we saw in Omicron is that there are over 50 mutations compared to that first what we call the reference strain, the first strain of SARS-CoV-2 that really started this pandemic. And a large number of those mutations are in what we call the S gene, and this is the gene that codes for the spike protein. A lot of our therapeutics have targeted the spike protein. The mRNA vaccines and the other vaccines, for example, they really have been targeting the spike protein. And so when we find changes to this component of the genome, of the SARS-CoV-2 genome, we start to worry, because that means that it is likely that the effectiveness of our vaccines and our therapeutics, even previous infection, will dwindle down rapidly over time. So what we know is that the spike protein, it binds to the same ACE2 receptors in human cells. And that seems to still be the case with Omicron as it was with Delta and other variants. Again, we have evidence right now that these changes have had some real consequences to the transmission, the transmissibility, and the effectiveness of the Omicron variant. We're also seeing that monoclonal antibody therapies are less effective against the Omicron variant than against the Delta variant. And I just wanted to give you all a brief look into one part of the genome so that you could see how different Omicron is from Delta and from Gamma, Beta, and Alpha. You can see here some of the changes are highlighted. And these changes, like I mentioned, right, some of them are having real implications for how well the therapeutics that we developed against Alpha, Beta, how effective they are. All right, so there's 70 times more of the Omicron variant than of the Delta variant, and of when you look at the human bronchus tissue in a lab setting. So that does tell us something about the infectiousness of the virus. What's really interesting, again, from lab work early on in early on in Omicron, which was really only a month prior, is that we find that there's 10 times less replication of the Omicron variant in lung tissue. And that suggests that maybe there should also be lower disease severity in humans. And we are seeing that in practice. So what we're seeing in the lab seems to really be translating in real life. These findings also do sort of highlight that you also would expect to see reinfection and vaccine breakthrough cases with the Omicron variant compared to the Delta variant, et cetera. At this point, it's pretty clear that the Omicron variant is outcompeting the Delta variant, and the Omicron variant is what we think of as the dominant strain of the coronavirus. So the changes that have happened in Omicron are leading to what we call extensive escape from neutralizing antibodies. And neutralizing antibodies are what your bodies produce when you are vaccinated or when you've previously been infected, right? Your body produces antibodies, and then these neutralizing antibodies, when they see the Omicron or another variant, they really should start to replicate, and they should really attack the virus. But because of the changes, because Omicron is so different from the Delta variant, for example, you are seeing reinfections occur at a greater rate than what you saw when Delta was reinfecting those who had been infected with Alpha. Right? There's more reinfection from Omicron among those who were infected previously with Delta. And we think we might see reinfection with the Omicron strain. So you were infected with Omicron once, and then 3 months later, you're infected again. We think we might see that as well. There is evidence that having a recent vaccine or a booster provides additional protection. And one study did show that there's about a 70% protection from the vaccine against hospitalization. The protection is higher the closer you are to when you were last vaccinated or when you last received a booster. So, this basically means that over time, immunity wanes. Over time, you become more susceptible to getting infected with Omicron. And this has real implications for how we go about our lives and how we assess risk. For individuals who have several or severe underlying conditions, or those who are of advanced age, they are really being encouraged to get not just a booster, but a third full dose of the vaccine and a fourth dose as well, because we're recognizing that they are the most vulnerable to hospitalization and death from SARS-CoV-2. And so they will need to be continuously vaccinated, at least while this variant is so rampant. One big issue that has come up often is this question about, what gives you a more robust immune response, natural infection or vaccination? And what we can tell you from the data so far is that vaccination really does seem to give a pretty robust immune response and protection against hospitalization and death, especially if you are recently vaccinated. Vaccination plus reinfection gives you also a very strong immune response. Reinfection alone, meaning relying on a natural infection, is a bit problematic because there's the risk of complications, the risk of having a more severe illness. And we are not yet at the point where we can predict which individuals who seem perfectly healthy are going to end up with a severe case of SARS-CoV-2. And when we are able to predict this, when we understand some of this a bit more, we can come back and target those individuals for vaccines and make sure that we give those individuals who are most at risk protection. So a question that keeps coming up also is, is the vaccine really effective against infection or transmission? And we're still trying to answer this question. What we've seen fairly recently is that with the recent surge in just infection, the case numbers, you do see a big gap between those who are unvaccinated and those who are vaccinated, with a much greater number of cases being among those who are unvaccinated. And this is looking at weekly cases in New York City. When you look at daily cases in Seattle, for example, you still see that big difference. And it looks like that difference is increasing over time right here. Another question is, what about disease severity? And here, this is another case where we are seeing that those who are vaccinated make up a smaller percentage of those who are hospitalized with COVID-19. And again, you can see a big difference here. This is looking at weekly hospitalizations in New York City. And you also see a very big difference between those who are vaccinated in the hospitals and those who are unvaccinated in Seattle when you look at daily average hospitalizations. So all of that is really highlighting why we think that vaccines are very effective, even against Omicron, even with all of the issues of waning immunity. So some of the questions that I had received by email had to do with this question about the trajectory of Omicron. Is it going to go away quickly? I think someone had said that the CDC director had mentioned that this is more of an ice pick instead of a wave, a true wave. Well, if you look at what happened in South Africa, you might have some clues as to what we would expect here. So within about a month, you really saw the peak, a very steep peak, and then a rapid decrease in cases. And when you're looking at the UK, where we're getting a lot of data rapidly, you also see that it's been about a month where we've had this massive increase, exponential increase in cases, and it's starting to come down. In the US as a whole, we also are seeing this exponential increase in cases. And in some states, you are starting to see the numbers come down. In New York City, for example, the numbers are starting to level off, and there's even some evidence that the numbers are starting to come down. Some other states are still in the exponential increase phase of Omicron. There's a lot that we don't know about Omicron and that we're quickly learning, a lot that we don't know about SARS-CoV-2. So, how severe of an illness does this cause in children? There is some emerging evidence that there could be a higher hospitalization rate when you look at Omicron infecting children as compared to Delta in children. However, our data are a little bit limited in this regard, and you also have to keep in mind that the sheer number of children being infected will lead to a large number of children being hospitalized. The rates are being calculated and recalculated to try to understand whether or not Omicron causes a more severe disease in children, or if it's relatively mild or the same as Delta. There are questions regarding long-term immunity. A lot of what we're learning about this is coming from real-world data and analyzing data as it's being reported. We are looking to our partners in the UK to learn a bit more about this, since they have pretty superior data. The death rates, I think time will tell if the death rates from Omicron continue to be lower than what we saw with Delta. There is some reasons to believe that ultimately, at the end of all of this, that the death rates will be significantly lower for Omicron compared to Delta, and same thing with hospitalization and disease severity rates. However, right, these death rates and hospitalization rates are what we often call lagging indicators, because you're really going to see the true impact of Omicron on these rates starting about 3 weeks after you reach the peak of Omicron. And so in a month or so, we might be able to say something more about the differences between Omicron and Delta when you look at death and disease severity rates. Another question that has come up has to do with testing. So recently, studies have reported that saliva samples are more reliable when you're looking for Omicron versus nasal. And previously with Delta, you would get the same test results whether you were using a saliva sample or a nasal sample. And this may have something to do with where Omicron sits in the body when it's replicating. So what this might mean in practice, and time will tell, is that there could be a percentage of individuals who are coming back negative when you are doing a nasal swab that will become positive if you collect a saliva sample at the same time. There are questions about, should I do a rapid test or an antigen test or a PCR test? Well, PCR tests are the gold standard. They are much more sensitive. They look for components of the virus. What you need to ask yourself is, what is the purpose of the test, right? So if you are looking at getting treatment, either one of these, could give the healthcare provider what they need to know to start treatment. If you're trying to prevent transmission, especially to your grandmother, if you're going to visit her, let's say, or some other individual who is immune compromised, then you might want to consider doing a rapid test right before you visit that person. There's some evidence that antigen tests, they can pick up on the time when you're shedding virus, the time when you're contagious. And so that could be a good justification to do the antigen test right before you go visit someone, because the PCR test will often take, the labs may take 2 to 3 days. We're seeing upwards of 5 days before you get the results back. Together, though, the tests can give us the information that we need. A question that I had received by email: if you test positive at home, what should you do? So if you test positive at home using one of these rapid tests, you should treat it like a true positive, which means go ahead and isolate, limit your contact with individuals, and then get a PCR test if it's possible, if the labs aren't overwhelmed, so that you can get that confirmation. If you get a negative antigen test, you need to be careful here. Most of these at-home test kits, these rapid tests, they do specify that you should take 2 tests about 2 days apart, because that will increase the sensitivity of the test. So if you get a negative test result and you've had close contact to someone who tested positive, you should definitely do that second test. If you have symptoms and you've had exposure, you should definitely do that second test. And if you have respiratory symptoms in general, you want to limit your contact, especially with vulnerable populations, because their immune systems are just not as robust as yours might be. And you want to cut down the risk of accidentally infecting someone. Right. Another question that has come up is, should we all be wearing masks? What kinds of masks should we wear? So masks do appear to be very effective in cutting down the transmission of even Omicron. But it's important to realize that how you're wearing the mask is really important. The fit has to be correct. It should be providing some kind of a seal around your face. Some organizations have went ahead and they've mandated the use of KN95s and double masks, double surgical masks. We were sort of in a very interesting situation early on in the pandemic where we did not have access to surgical masks. And so people were asked to make their own masks. And there were lots of YouTube videos, and the CDC put out guidance about how to make your own mask. We're not at where we are in the pandemic is now very different. We now have access to surgical masks and even KN95s. And so cloth masks, because they're so variable in quality, you see children wearing them in different ways. A lot of times they don't provide a good fit. They might be dirty. I've seen that a lot, dirty masks or ripped masks. You really want to avoid those. The mantra early on in the pandemic was, my mask protects you, your masks protect me. Well, I think it's important that we recognize that your mask also does protect you, right? My mask also does protect me. And we've seen this time and time again when we've looked at healthcare workers who treat COVID-19 patients. When they're wearing their masks correctly, they are able to avoid infection. And we've also seen it in a number of cases recently where parents have picked up their college students, and the college student has said, before you come get me, I just want you to know I tested positive. And so the parents who have worn their masks, picked up their kid and drove with the window open, and then the child isolated at home, those families were able to avoid widespread transmission in the household. And so, you are seeing evidence of how well masks work, but the problem is they have to be worn correctly, and it has to be a high quality mask. It's also important to realize that masks are part of this layered intervention approach, right? We have vaccines and boosters. social distancing, masks. And all of these together can really provide good protection against transmission. And this is especially important when you're dealing with vulnerable populations or immune compromised populations. Another question that comes up often is, how are we going to move forward and live with the virus? And there are a few things that we're keeping an eye out on. Once we have a safe and effective treatment for those who become ill with the virus, I think we'll really be at that point where we can move on and live with the virus. We're not there yet. And treatment goes hand in hand with testing, right? You need to have good tests that could rapidly tell you if someone is positive, and if their symptoms are severe, then they have access to a safe and effective treatment. I hope we're moving closer to that point. The other thing we need to keep in mind is the hospital and the EMS capacity. We're not at a point right now where our hospitals are able to handle the overwhelming need for their services. And that is not really living with the virus. So our healthcare workers, those who are working in hospitals and in emergency departments, they're really struggling right now. I spoke with a few from our local area here in the DMV, and the overwhelming majority are really struggling with staffing, with morale, and there is a lot of exhaustion among them, which is affecting the care that we need for non-COVID emergencies. And so if our healthcare workers are not able to really live with the virus, then we aren't either, right? We're still seeing more and more states having to declare public health emergencies because they need federal aid, they need help to staff their hospitals. And another thing to keep in mind is right now, if someone is admitted to the hospital and then they test positive, that means they have to be in isolation. And that is an added cost and an added layer of logistics, because we need to protect patients, other patients, from getting infected from someone who tests positive while they're in the hospital. And living with the virus, also assumes that future variants will be less severe than Omicron, for example. If a future variant ends up causing more severe illness and is more transmissible, then we're sort of having to slow down our move towards living with the virus. A lot of us are starting to, go back to doing in-person activities, many of us with masks on, and we will have more and more indications about when it's safe to really let go of some of the interventions. We're just not there yet, but vulnerable populations will continue to need to wear masks, and individuals who have cold-like symptoms should also wear masks to protect those around them who might have immune compromising conditions. I like to remind people that in the US, we have a very large percentage of individuals who've been surviving with immune compromising conditions that used to really lead to death within a few months or years. And now they're living longer because we have lots of therapeutics. But the flip side of that is they're also more vulnerable to viruses like SARS-CoV-2. And there are a number of future challenges, and I'll leave the slide up here to give us some time to answer other questions that may have arisen. Thank you.
What a wonderful, informative presentation. We just had an opportunity to check to see if folks who started with us are still with us, and the rate of people who have stayed for this entire presentation, given Zoom fatigue, is quite something, Dr. Roess, and that's a testament to how on point your presentation was with the questions I think that we all have. I just want to start with a couple of quick questions. We won't take much of your time, and I'm not going to take much of your time, but I wanted to ask, you mentioned human-to-human transmission and the efficiency of that transmission. That seems like it would be quite critical to when a coronavirus emerges in humans, what we think is going to happen. So is there a way kind of immediately to understand the efficiency of human-to-human transmission in a coronavirus?
So there is ongoing work to identify which genes might be associated with more efficient transmission. We were really lucky with the first SARS and with MERS coronavirus that those two, once they're infecting a human, you don't see as much human-to-human transmission. They're just not as efficient. Now with SARS-CoV-2, we have another virus to look at, and more importantly, we have variants that are starting to give us more clues about which genes in the coronavirus are we seeing in Omicron, the Omicron variant, for example, that we didn't see in Delta and that we didn't see in MERS or in the first SARS. And we are starting to wrap our heads around what that might mean when we find coronaviruses in the future, or when we find other variants of SARS-CoV-2. We might be able to more quickly predict with more accuracy which variants and which coronaviruses might have pandemic potential.
And you mentioned that there's an assumption, and I think it's one we've all heard, that the variants will be progressively less severe. That depends on whether they are presenting the same way. You talked about the S something.
Right.
Right. And what one concern is that if they show up in you mentioned that if something happens, then our current vaccines and treatments would likely not be as effective or effective, right? So that remains a possibility.
Right. So with Omicron, we found that a lot of the changes or the mutations were in the spike protein, in that segment. Yeah. And our vaccines and a lot of our therapeutics target the spike protein for good reason. And so when that spike protein changes, then the target of that mRNA vaccine has also changed.
I see.
And so that's why we're seeing that the effectiveness is less than it was against the Alpha and even the Delta variants. And so we have to keep an eye on changes to the spike protein, because that's the target of a lot of our therapeutics. But there are also other changes in other parts of the genome that we're looking at carefully so that we can understand what the risk might be in the future for more severe illness, et cetera.
Perfect. And one final quick question, and then I'm going to move to ask Anna to join us. You also mentioned that while the Omicron variant, there's much more of it seems like in our systems, that it's, I think, replicability in lung tissue is less than with Delta. Is that right? So is it a combination? Do researchers believe it's a combination of that and vaccination that is contributing to the fact that there is apparent less severity for vaccinated individuals and with this variant than with Delta?
Yeah, and there's a lot that we're still trying to learn to answer some of those questions. Now, it does seem that in general, Omicron causes less severe illness. We know that the vaccines also prevent less severe illness. And so over time, we'll be able to collect more data from individuals who are unvaccinated and those who are vaccinated and compare the severity of illness among these two groups. The data that we're getting right now is showing a big difference in disease severity and even infection among vaccinated and unvaccinated. But there are still quite a few gaps that we need to fill in so that we can better say definitively, is Omicron really causing less severe disease as a whole, or is it a byproduct of more young people getting infected, more vaccinated people?
More vaccinated. There's many variables. Thank you very much. Anna, could you join us?
Absolutely, happy to.
Great.
Great. Dr. Roess, one question that has come in from the audience. As you interact with the public, to encourage vaccination, masking, and distancing, what message of motivation do you try to convey? You've spoken about fatigue, and it's been 2 years now. How are you trying to keep people motivated?
Yeah, so, right, this is a really challenging question here. And I think one thing we talk a lot about in our circles here is that the fact that the hospitals are overrun and that our healthcare providers, are struggling, that should be enough of a motivation for individuals to wear the masks and just be a little bit careful right now, just so that we can get our hospitals through this and so that it's no longer an emergency situation. And I think for some people, that is a good motivation. Another group of people seems to be motivated by the idea, you don't want to infect your grandparents, or you don't want to infect individuals in your household who are immune compromised. And there's so many of us who are now, immune compromised, who are living with taking immunosuppressives. So that seems to also be a good motivator for some individuals. It is increasingly difficult to get that message out. And there does also seem to be a disconnect between the realities of emergency departments and the realities of hospital capacity and how people are perceiving the pandemic, right? A lot of people have felt like, it's time to move on. However, our hospitals, by all accounts, are going to continue to struggle for the next month. And right, it's just I think a challenging job, especially for the communication experts, to try to figure out how best to communicate that.
Great. So true. Another question has come in about one of the bullet points on the slide here. Your point about a future surge in vaccine hesitancy for diseases, that are currently or once preventable. Can you expand on that a little bit?
Yeah, this is one of our worries right now. There has been a real surge in vaccine hesitancy, even when we are looking at non-COVID or non-SARS-CoV-2 vaccines. And it's happening, during the last 2 years. And this is really worrying a lot of us. Schools right now, they have been for decades, they've been requiring vaccination among preventable diseases, and that has worked beautifully. But we are seeing more and more, reports of measles outbreaks. Right before the pandemic, there were small clusters of once preventable diseases, and there is a growing number of parents who are expressing vaccine hesitancy among some of our oldest and safest vaccines, and we're starting to see an indication that COVID-19 vaccine hesitancy is also creating or leading to even more vaccine hesitancy among some groups. And this is really concerning. We cannot afford to go backwards in time, especially when so many individuals in our community have underlying conditions, right? I mean, a measles outbreak in a population where 30% of folks are immune compromised or have diabetes or something like that could be really catastrophic, right? And so we want to figure out a way to improve trust in public health and medical experts, and to really try to get ahead of this future surge in vaccine hesitancy, because I think it is coming and we have an opportunity to do something about it now. And time will tell, if we really do act quickly and prevent it. Unfortunately, in the US, a lot of times what we end up doing, and in a lot of other countries too, we end up really being reactionary. And for infectious diseases, prevention is so much better. That's why a vaccine that can help decrease hospitalizations is so much better than trying to figure out a treatment once someone is in the hospital, right? So this is really worrying a lot of us, this future surge in vaccine hesitancy.
I think it's so important. And one of the things that worries me is that there won't be space for what Alan Leshner calls a bidirectional conversation, where people, where their fears and concerns, whatever is driving them to have hesitancy, is not respected. So that there's not a conversation, that it's more like a one-way, you're wrong because you have concerns and we're right, And I wish that there was a way to have a national conversation that would respect this, whatever this underlying, wherever it arises from, and address it. Anyway, that's my bias.
You're absolutely correct.
Yeah. Anna, do we have other questions? I know we've kept Dr. Roess beyond when we.
Yes. Yes. Thanks, Dr. Roess. Another question has come in about another bullet point on this current slide. Would you mind discussing the bullet point regarding depleted healthcare and the public health workforce? Could you discuss that a bit?
Yeah, so in 2008, we had what we call the Great Recession. And at that time, I was working at the CDC as an outbreak investigator. And one of the reactions, or one of the strategies to address the economic issues, were for health departments and local governments to furlough employees. And in a lot of health departments, what you saw was that public health staff were told, you need to take one day off a week, you're not going to get paid. And so this went on for a while. And as a result, lots of people left the public health sector. They left state and local health departments, and we've never really recovered from that. And we've been warning for a couple of decades now that our public health infrastructure is not in a place to really respond to an emergency. Lots of local health departments, they have to go to the state or to neighboring departments to ask for assistance whenever there's any kind of public health emergency. And we saw the consequences of that play out time and time again, especially with this COVID-19 pandemic. We need a long-term solution to this. I was talking with colleagues at various health departments, and they're really continuing to struggle. Like right now they're getting funding, but it's 2-year funding or 3-year funding. They've had a lot of contractors come in to help out with contact tracing, but they were on very short-term contracts, and there aren't resources for this. So we have to figure out a way to do better when it comes to improving our public health infrastructure. And there's a lot that can be said about our public health surveillance infrastructure and how we've known for a couple of decades that it's really not where it should be. We've had to look to our partners in the UK, for example, in Germany, to get some information about what the variants of concern are going to be. And we're trying to do better, right? But it's a whole conversation about how do we improve this aspect of it.
It's really important for us to hear as an advocacy organization, advocacy alliance, and a policy alliance. So thank you for that. And Anna, I think maybe if you have time, Dr. Roess, for one more question.
Sure, yes.
Wonderful.
Great, thank you. Dr. Roess, could you comment on what is known about whether the major risk factors for severe COVID are conserved with Omicron, in particular age and obesity, and with or without vaccination?
So there does seem to be preliminary evidence to suggest that, but we also are still early on in Omicron to definitively or close to definitively answer that question. But in general, we have seen throughout the pandemic that those who are obese have an increased risk of more severe illness, and those who are elderly have an increased risk of severe illness and death. It seems that is still the case with Omicron.
Well, this has been just terrific, Dr. Roess. I'm just going to do a little bit of housekeeping, and but I want to say is, could you join us every week, because you're fabulous.
Oh, thank you. That's very kind of you. I really enjoyed this conversation.
It's just been terrific. Thank you so much. And I'm going to skip back to my cheat sheet for the final. Or actually, Anna, can you join? Because you're much better at wrapping up than I am. Sure. I know that Sue Peshin is joining us next week, which is just an absolute honor.
Yes,
so I can.
Yes.
So if you wouldn't mind
Sure. Yep.
Taking
So
it from here.
yes. So folks, as you can see on screen, Sue will be joining us next week. She is the president and CEO of the Alliance for Aging Research. This session will be a special discussion in our series highlighting our 2022 Advocacy Awards honorees, and mark your calendars for March 16th for our 2022 awards. And Sue is going to speak with us about how the Alliance has evolved under her leadership, their priorities for this year, and her vision for successful advocacy. So thanks so much for joining us today. And thank you so much, Dr. Roess, and have a great rest of the day, everybody. Bye now.